Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello and welcome, listeners. This is Kevin MacPherson, and we are continuing our interviews of different AAOMPT presenters. This time, I have the privilege of speaking to Kyle Feldman regarding his talk, which was titled Patient Communication, the Way to Every Patient's Heart. Now, just a very brief background on Kyle. He graduated from Shenandoah University with his DPT, and then he underwent a year-long residency through VOMPT and received his OCS and CSCS in 2016. He subsequently went on to receive his fellowship training from the University of Illinois at Chicago's program. He currently runs and operates the ReShape physical therapy clinic based out of Winchester, VA, and that is where he also mentors residents through the VOMPT Residency Program, as well as he is a faculty member for the Shenandoah University DPT program and serves as a mentor for AAOMPT. So Kyle, I'll start off by saying welcome. How are you doing today?
Thank you so much, Kevin. I'm doing fantastic. How are you?
I'm pretty good. I want to say that I would listen to your talk, and I was, it's just an area that I always find very important. I think even though they call them soft skills, oftentimes there's just so much more to it. And it's an area that we really should spend more time getting our students to understand, especially at the entry level. But I'm getting ahead of myself. So let's start off by just asking you about the talk. What was the driving force for this talk? Did you see something in the clinic, or did you get feedback that said, hey, I need to talk about patient communication?
Great question. So I'm going to start a couple things, but one of them is because you talked about UIC, and we both kind of have a strong affinity to that. So I'm proud to do this with you. One of my mentors was Michael O'Hearn. He had won an award at AAOMPT a couple years ago. And he was a great mentor, and I was so excited to learn all his manual techniques. And after our first evaluation, he bashed me on my communication skills, things that I thought were my strength. And that was a big wake-up call to realizing that maybe what I thought was my strength wasn't. I come to find out later on it actually was a strength. I just wasn't using it properly. And so then it became an interest of mine to realize that I need to not only help myself, but try to help others who are struggling with the same concept.
That's great insight to see how you picked something up from a mentor. You were able to evolve your impression of yourself and start really some of the metacognition processes into improving your communication skills, despite being bashed by Michael, which I'm sure is a very uncomfortable situation. Great clinician.
Beyond Michael and what I learned from him through UIC, once I started realizing that, I started to look back at myself and realizing why communication was important to me. And I think it's been an evolution. So to start, I kind of looked at my own experience in healthcare. You go to a PCP or a specialist, they have about a few minutes to talk with you. They're usually trying to, catch up on notes between, they're trying to organize their thoughts. They're rushed, they're overworked. And based on the research, when you go to a PCP or a specialist, the amount of time that they actually let you talk and tell your story is 11 seconds. So not only are they rushed, but they're rushing you as a patient. And so that made me think about someone like my grandmother, who had a couple health conditions towards the end of her life. And she'd go to the doctor, and I'd have so many questions I wanted her to ask, and she'd come back home with none of them answered. So I felt like either they didn't value her opinion, or they didn't listen to her, or it just was too quick. So I realized that there are some issues in the healthcare world with communication. And then there was one patient in my first 2 years of practice that really, this is before fellowship, that made me realize, I need to look at communication. Patient came in, cervical pain, not really cervical, but more just pain that radiated down her arm. And she had that silver dollar Cloward sign. And with that, I explained to her, hey, I'm going to treat your neck. This is going to make your arm better. I treated her cervical spine. I treated her arm. I used the best research at the time, and she was getting better. But after visit 5, she stopped showing up. And new grad, I didn't really think too much of it, but she called my boss and said to my boss that I never addressed her issue. She asked her obviously more questions because my boss was a great communicator. And it found out that I never touched that silver dollar area on her back. Had I done that, visit 1, visit 2, visit 3, even massaged it for a couple seconds, addressed her concerns, met her where she was, I could have probably had a totally different experience with her. And so that, after working with Michael, made me realize, yes, this communication is a very, very powerful tool in a manual therapist toolbox.
Great stories that really highlight your evolution as a practitioner, your evolution as a communicator, and arguably have been honed from the entry point of your mind saying, I've got to be better, which happens for a lot of fellows that lead into fellowship, but also the continued processes. So it's good to see that you started that critical thinking. It's good to see that that's continued, and it's good to see that you're modeling that for the rest of us through your talk. Now, I think that also kind of plays in a little bit to a early observation you had of a fairly decently known debate between Chad Cook and Adam Meekins recently. You said that there was something that they both agreed upon about what patients want in a treatment encounter. What was that, and how does that tie into your experiences that you had?
So, being on the conference committee of AAOMPT, I was really looking forward to Chad and Adam speaking on our platform. Sadly, that didn't happen, so we had to listen to it on YouTube. But for me, I respect Chad Cook. I think he's a phenomenal researcher, a great speaker, and great for our profession in AAOMPT. Adam, he's a therapist. He's a great therapist, and I respect him for his ability to challenge people's thinking and building his brand. He has a brand about exercise and movement and getting people moving, and he does that well. I do disagree with a lot of what Adam says because I think he has experiences that are poor with manual therapy back in his home country, and that's unfortunate. I think if he were to come here and see how some fellowship trained manual therapists work, he would agree with what we do. I really truly do after hearing him speak. Um, so they were on a podcast, and the topic of that was manual therapy. But at one point, they started talking about patient communication. And Chad mentioned that communication was the most powerful tool in a therapist toolbox. He said there's 3 main things that a patient wants. That's to be respected, to have a good experience, and to be able to tell their story. I thought those were great points, things that I've been thinking about, especially after fellowship. And then after that, Adam agreed, and he agreed pretty strongly. So to me, to have 2 different people from 2 different camps that are debating about a topic agree on something so strongly, that made me even more emphasize that this is important. This is something we really need to be harping on in schools, even as young, and residencies and fellowships, really getting this honed in.
Excellent observation. I really am glad that you jumped on that because I agree with you. They call them soft skills, like you mentioned before, but really they're turning out to be ever so much more important. Now, one other aspect of communication that you'll hear thrown around a lot, there's a little bit of debate on the percentages, but they say that really the verbal aspect of communication between 2 people in a face-to-face situation is only about 10% of the communication that actually occurs. And a lot of it's nonverbal communication. So, what recommendations did you provide for improving that face to face communication during a patient care uh, situation?
Thanks, Kevin. Yeah, I have heard those numbers too. I personally think it's more 70% to 30%, only because when we're with the patient, because patient experiences are a little different, um, you're going to have this period where you have to educate. You have to provide them information that they need, and so that number goes up a little bit more for us, I think. Uh, but overall, I think nonverbal communication is huge. Things that we talked about was matching someone's posture. Someone comes in, they're very loud, robust. You want to match that. if you're, like myself, if you're a 6'2", 215-pound therapist and you have a 13-year-old patient who has the terrible triad or just had an ACL surgery, you don't want to be loud and robust. You might want to kind of sit back in your chair a little bit, be a little smaller, make yourself smaller, um, to make them feel more comfortable. Getting on their level. Someone who's taller, get taller. Someone who's shorter, get shorter. Making sure you have a friendly face, good eye contact. Um, don't be behind your computer. Don't shake your leg or fidget your pen. All those things are so valuable as nonverbal cues in communication. Also, our hands, our manual therapy, us as manual therapists, that's a nonverbal communication skill. So we need to make sure we're using that. As far as verbal communication, making sure to restate what they're saying, making sure you really understand what these patients are saying to you. Because sometimes you think you do, but if you repeat it back to them, it's not even close what they were trying to say. Making sure to use analogies. I talk a lot about using those. We always tell these students and new graduates to use layman's terms, but that doesn't always make sense. So if you can use analogies that make sense to the patient, I always say, what are your hobbies? You asked that day one. Use that in your analogies. Someone's a gardener. Use the garden hose analogy. Someone's a woodworker. Talk about it with wood. Be creative. Find things that they understand so that this communication you're providing them makes sense to them.
So along our journeys as a human being, uh, where should we have picked up on a lot of these skills, or where might we have picked up on a lot of these skills and maybe forgot about them? And I'm pulling obviously a direct quote from your presentation.
Yes. So I remember a couple years ago, Bill Boisenaut, who has been teaching at Shenandoah until he retired. Um, Great speaker, super smart therapist. He spoke at AAOMPT about the soft skills and how this needs to be taught, how we learn it at a very young age, and then we kind of forget about it. And those soft skills, they include listening, self-control, empathy, having a sense of humor, being funny, and being compassionate. We learn these things when we're young, and then we get to college and we start learning our interest. Well, for us, exercise, biology, kinesiology. Then we get into PT school and we learn the details of how to be a PT. Then we go to residency and we learn about the orthopedic world. And then we go to fellowship and we learn about the hands-on and the clinical reasoning. We dive deeper and deeper into details and minute differences to hone that craft. And we sometimes forget about that big concepts that we had before that. I know when I came back from Chicago, because I moved there for fellowship, and I came back home and I was sitting in the car with my dad and we were having a conversation. And he looked at me and he said, "You're less caring like you used to be." And I was like, what are you talking about? But I get what he was saying. I was so science driven. I was so fact and research and thinking that I kind of lost that. What do you feel? How do you feel? I was just so ingrained into the science. And so that for me was a good kind of wake up call that we need to sometimes sit back at all phases of our learning and put ourselves in the shoes of the people around us, our friends, our family, our patients. Um, a perfect example of this, we go to a restaurant and we grade fast food chains on their customer service. We go to retail stores and we grade them on how friendly they are to their customers. Why shouldn't providers and physical therapists and chiropractors and surgeons be graded on the same thing? So I think we need to be really, really smart and really detailed, but we've also got to remember who we are as people and remember those soft skills.
So, Kyle, much of what you're talking about right now falls under an umbrella term of patient-centered care. There's also a component in there of shared decision making, like bringing that person along with you. You talked a little bit more about other strategies and tactics for shared decision making. Can you talk about those a little bit to give our listeners some insight there as well?
I think for a long period of time, we had this role where, I'm the doctor. I know I'm smarter, I'm superior, and that's provider centered care. And that's what it really had always been. And I see patients who are in their 70s who come to me and I ask them a question and they're like, "What? You're supposed to just tell me what to do." And I think that concept just it needs to go away because we are not smarter. People know their bodies a lot more than we do. Now, if you've been working with someone for 30 years as a provider, you might have a good experience as a PCP. But to see someone for their first experience and to say that we know what their body's doing, that's hard to say, especially as we're learning that MRIs don't always tell the whole story. Or things can come up on an MRI and they don't actually aren't the driver for the symptoms. So for me, I think that leads us to the idea of if we're going to solve an issue and we're going to help make people get better and use exercise and understanding how their body moves and affecting how their body moves, we have to get them on this same page of, hey, I'm involved in my care and I understand what's happening in my care.
These are great bits of insight for our listeners. Now, part of that process is also listening to how they respond to some interventions. And one of the other things that you mentioned was you've heard patients say, "Yeah, that made me a little bit better." But you said that hearing that is not enough. Why is that not enough if they feel a little bit better?
So I really work on this with a bunch of my students. I always talk about that with them. I also do it with my residents, and then right now I have a current fellow in training. And here's my thought on it. If we are objective with our manual muscle testing, our range of motion testing, why should we not be objective with understanding how symptoms change? So for me, I think that we need to put it on a percentage scale because your little bit better and my little bit better could be very different because your 3 out of 10 pain could be very different than my 3 out of 10 pain. And we know that people's experiences of pain are different. The research has shown that over and over and over again. So if someone interprets pain different, they're going to interpret what better is. They're going to interpret what beautiful is differently. So unless we can quantify it in some capacity, we can't know if change happens. I'll give you a perfect example from 2 days ago with my fellow in training. She did a mobilization on a patient, and the patient said a little bit better, and she was going to leave it there. And I said, no, let's quantify. And she said 10% better. So the patient says 10% better. I asked the therapist, do you want to continue with that intervention or do you want to try something different? She said, try something different. We did some soft tissue technique in that same region. We hit a different muscle. Patient got up, we reassessed. Patient said, better. So I again said, what percentage? She said 50% better. So I asked the same therapist, would you want to continue that intervention? Her response was absolutely. If we think little bit means 50%, we might keep doing an intervention that's not as effective as another one that we could be doing. Our goal with clinical reasoning is to be more efficient. So if we can be more efficient by using quantifiable information, let's do that.
Great insight on both the educational process for your mentees, but also some things to consider. Now, I'm going to play devil advocate here for a second. Let's say that, I'm a listener. I've listened to all of this podcast so far, hoping for a small nugget of new information because I really like this subject matter. And I didn't hear anything. There was nothing that's new to me. You made a recommendation to the audience about maybe how to fact check yourself. What was that recommendation?
Great question. So when I was in fellowship, we had to record our subjective examinations. We had to record ourselves talking to a patient. After that, we had to reflect. We had to watch it and reflect. Then we had to have two of our other fellows in our class watch us and reflect. That was one of the most humbling experiences I think I've had. And I played college sports and I've been humbled a couple times, but to see yourself do what you think you're doing and not do it as well as you think you're doing it, or saying something and realizing the patient didn't pick up on what you said was very valuable. That's where I learned about the whole getting big and getting small was watching myself. watching a couple of my classmates who just gave that impression that it wasn't comfortable for the patient, or that, wow, that person did a really good job of that. And so that for me, that reflection, that experience was very valuable.
And I think that's wonderful advice as part of my participation in other fellowship programs, as well as in real time at the University of Florida. There's been several times where we've looked at video of myself doing evaluations, and I can tell you more often than not, even post fellowship and post training, there are times where I'm like, yeah, I could have done that a lot better. So I fully agree with that observation. Now, Kyle, I want to just finish by saying that was an excellent presentation, and I really look forward to some of the things that you will be coming forward with other activities. But I wanted to real quickly get your insight. I try to ask this of any of the interviewees that I work with, especially when there's only one of them, is that if somebody was listening right now, considering fellowship, haven't really pulled the trigger on that one yet, what recommendations, good or bad, would you have for them to consider prior to maybe pulling that trigger or not?
So for me personally, it was the best thing I could have done for my career, and I think personal life too. I believe I truly grew as a man from that experience. I know what UIC had to do with the caliber of that training, and I think it pushed me in a lot of ways that I needed to be pushed. So for me, it was one of the best things I could have done. Um, I put a lot of effort in. I moved away halfway across the country by myself to do it. So I put full effort in. I did everything I could there. I did things outside of it. I did extra traveling to Nicaragua with the UIC program. I did some free medical clinic work that I created while I was there. So I put as much as I could into it. I studied extra. I did as much as I could. And I think that's what everyone else should really try to do is when you're in that experience, immerse yourself and make it happen. But you cannot forget about your compassion and your caring side. You got to remember that people are in pain, and what you do to help them is most importantly to care. Once you care and once you get that alliance and you show you care, then all the other manual stuff comes. I know when I started UIC's fellowship, Carol said, this is a clinical reasoning fellowship, not an orthopedic manual therapy fellowship. And at first I was kind of bummed, wondering why I came all the way across the country for that. But I'm so happy that that is what it was. I've got the techniques. I can do them, and I can do a lot of them. But what I learned was way more valuable for myself, for my patients, and for all those around me.
So these are excellent bits of insight as well as advice, Kyle, and I really appreciate the time and the ability to do an interview with you. Now, I know some of our listeners will likely have some follow-up questions for you. What's the best way for them to reach out to you if they did have some specific questions or resources that you might be able to provide them?
So I'm on social media. My name's Kyle Feldman. You can try to find me on there. I also have an email, kylefeldmandpt@gmail.com. So I'd love to help out that way. Like I said, I'm involved at Shenandoah University, the VOMPT Residency in Virginia. I help mentor other fellows. I'm helping with AAOMPT, which is based out of New Jersey. So I'm involved in a couple different things, but hopefully social media or email would be the best way to reach out.
Perfect. Well, Dr. Kyle Feldman, I again appreciate your time, and I hope you have a wonderful rest of your day.
I hope you have a better day.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at AAOMPT.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.